Welcome to my lecture series again. My name is Dr. Arinze Ikeme. I am a nephrologist and also a hospitalist, so I do work inpatient. Today, this lecture on pre-op evaluation is going to be for medical students who are aspiring to be physicians, who might be working in the inpatient settings or internal medicine, and also for other providers, primary care physician, family physicians, cardiologists, especially, or other providers who might offer some form of pre-op evaluation for patients who are going for surgery and need to be evaluated to assess their safety or their risk profile as before they go into surgery. So I'm going to run through this very short presentation, and I hope it's helpful to you. So first of all, I'm going to, discuss what a pre-op evaluation is, why pre-op evaluations are important, what are the major components of a pre-op evaluation, which would include the urgency of the procedure or the surgery, the type of surgery, and the risk attached to that particular procedure, the patient's comorbidities that will impact their surgical risks. And these, of course, they need before you get an informed consent prior to the procedure, because it's an informed consent. So they need to be informed to give their consent for the procedure. So you want to be able to discuss their risk for the surgery in being addressed or being planned. So what is a pre-op evaluation? Is a clinical assessment preceding any intended procedure, whether it's surgical or non-surgical, in order to provide the patient with evidence-based information about their perioperative cardiovascular risk. It involves addressing and acknowledging the risks involved in the intended procedure in view of the patient's chronic medical conditions and other risk factors, including their age, of course. Why is a pre-operative evaluation important? It provides information that's needed for the patient to understand their risk of morbidity or mortality or cardiovascular complications, both during and after the procedure. It provides a non-biased guide for the patient to make informed decision whether or not to proceed with the planned procedure. It also establishes an objective platform for the anesthesiologist and the surgeon to provide advice and recommendations to the patient prior to a procedure. And of course, it provides evidence-based information for both the patient and the surgeon to weigh the risks and the benefits of a planned procedure. So what are the major components of a pre-op evaluation? So the major components will be: one, what's the urgency of the procedure, the surgery? Is it an emergency procedure? Is it something that has to be done immediately? Is it semi-urgent? Is it an elective procedure? Then the second thing will be the type of surgery and the risk attached to it. Of course, there are low-risk surgeries and there are high-risk surgeries. So you want to know the type of surgery. And then you want to focus your attention also on the patient and look into their comorbidities that may impact their surgical risk and their perioperative morbidity and mortality. So let's talk about the urgency of the procedure. An emergency procedure, if it's an emergency procedure, there is no pre-op evaluation. For instance, someone has an intracranial bleed with impending herniation, brain herniation, a bowel perforation, of course, except for the micro perforations, like diverticular perforations, unstable aortic dissection, aneurysm ruptures. These are emergency situations. You don't need a pre-op evaluation, because if you don't take them to the OR, they die, pretty much. Then the urgent procedures like acute cholecystitis, gallbladder inflammation, displaced hip fractures, bowel obstruction. So in those cases, you want to get the cardiologists only if these patients have two major conditions. If they have a severe valvular stenosis, they have, like, for instance, an aortic or mitral stenosis, or if they have a severe pulmonary hypertension with a PASP of more than 70 millimeters mercury, then you want to get the cardiologist to weigh in. And, this doesn't mean the procedure can't be done, but, you might be well off doing this in a tertiary hospital when they have some cardiovascular support, just in case things go south. And then, of course, for elective procedures like knee replacements for severe osteoarthritis, hernia repairs, organ transplants, everybody pretty much would get a pre-op evaluation. So then we start looking at the procedure itself. There are low-risk procedures, meaning there is less than 1% risk of a cardiovascular event or mortality. Breast surgeries, dental surgery, eye surgeries like cataracts, skin biopsies, small tumor resections. These are low-risk procedures. Intermediate risk procedures have a 1 to 5% risk of things going bad, like symptomatic carotid artery surgery, endovascular aneurysm repair, head and neck surgeries, hip surgeries, intraperitoneal surgeries, kidney transplants, spine surgery, etc. And then, of course, the high-risk procedures, more than 5% risk, aortic or major vascular surgeries, adrenal resection, pneumonectomy, lung, heart or liver transplant, repair of a perforated bowel, revascularization or thrombectomy of lower limbs, etc. These are definitely high-risk surgeries that has a higher risk of things going bad. So then you look at the patient's comorbidities that will impact their cardiovascular risk and perioperative complication risks. So there is the revised cardiac risk index, which are 6 independent variables that was revised in 1999. And each of these will give 1 point, each of these 6 variables. And if it's going to be a high-risk surgery, like we mentioned, then they get 1 point. History of ischemic heart disease, they get 1 point. History of congestive heart failure would get 1 point. History of a stroke will get 1 point. If you're diabetic and you're on insulin, you get 1 point. If your pre-op serum creatinine is more than 2.0, which is around CKD stage 3B4, you get 1 point. And so the way we interpret this risk score is we add up all the points, and if your point is 0, then it's very low risk, 0.4%. If it's 1, it's low risk, it's 0.9%. If it's moderate, 2 points, it's 7% risk. And of course, if it's 3 points and above, then it's 11% and above, it's high risk. So we kind of try to put this all together, to inform the patient so that they can make an informed consent. So if a patient is more than 65 years old, or if they are less than 65 years old with cardiovascular disease or a risk score of 1 or more, then you need to get a pre-op pro-BNP. The pro-BNP, it's kind of a rough way of estimating the stress on the heart already, or some underlying heart disease. If the pro-BNP is more than 300, patient is high risk and for a cardiovascular event, and you want to get a post-op troponin and EKG, to assess for a silent post-op myocardial infarction, which means that they don't have to have a chest pain. Just post-op, if the pro-BNP is more than 300, just get a troponin after the surgery. If the pro-BNP is less than 300 or normal, then you can proceed with a functional status assessment. Again, this is for those patients who are either more than 65 years old or they are less than 65 but have some kind of cardiovascular disease or a high revised cardiac risk index score. And the functional assessment, if you're less than 65, they usually do a metabolic equivalent assessment, which is a functional assessment I might not go into now. But just as a general rule, if they have up to 4 MET, this metabolic equivalent is the amount of oxygen consumption the amount of oxygen consumption in their most active state. So for instance, if a patient can climb 2 flights of stairs, that's giving 4 METs, because 1 MET is your metabolic your oxygen consumption at rest. And so 4 METs is if you can climb 2 flights of stairs or if you can walk a block. So if you're up to 4 METs, then they proceed with surgery, of course, if you're more than 65. If you're less than 65, if you're more than 65, then we usually do what we call the frailty test rather than the metabolic equivalent assessment. And so again, as I said, the functional assessment for less than 65 is the metabolic equivalent. 1 MET represents resting energy expenditure and is about 3.5 mils of oxygen per kg per minute. If it's more than 4 METs, as I said, proceed with surgery. If it's less than 4 METs, cardiologists might consider doing a stress test. So sitting and watching TV is 1 MET. And as I said, if you can do some brisk walking, or you can golf, or you can walk, a few flights of stairs or walk a block, then that's at least 4 METs, and you can proceed with surgery. It means that your functional status is pretty good, actually, and so you can withstand the stress of the surgery. Of course, I said if you're more than 65 years, the frailty test, if you look at the diagram, you'd see elderly patients at different levels of functional capacity, from running to walking, to walking with a cane, to walking with a walker, to having a standby person despite being with a walker, to being wheelchair bound, to being bed bound, to being terminally ill. And so usually you just present them with this picture and they point where they think they identify with, where their own functional level is. And that would help you to assess them, to know if they can withstand the stress of surgery. So, of course, there are other pre-op evaluation the anesthesiologist will do, like the Mallampati scoring for intubation and airway protection, obstructive sleep apnea, risk evaluation, especially during the immediate post-op period or during lighter sedations for a procedure, whether they are at risk for respiratory failure. Of course, as far as the Mallampati scoring, as you go higher in the class score, then their risk of intubation difficulty increases. And so the anesthesiologists want to know about this in their pre-op evaluation. The stop bank, if a patient doesn't have a formal diagnosis of sleep apnea, then you want to screen them for sleep apnea with the stop bank mnemonic. Do they snore? Do they feel tired? Have they been observed to have apneic spells while sleeping? High blood pressure? If the BMI is more than 35, age more than 50 years old, neck circumference more than 40 centimeters, or if they are male, these are all scores that will help you, know if they are at high risk of having sleep apnea. And special considerations, of course, if these are cirrhotic patients, you have to consider the MELD score. If the MELD score is more than 20, then they are really high risk. If it's less than 8, they are lower risk for surgery. For sickle cell anemia patients, you have to make sure they have the optimal hemoglobin before high-risk surgeries. For high-risk surgeries, they actually want their hemoglobin closer to 10 than the usual 5 milligrams before you transfuse. If they have adrenal insufficiency, you want to give them some stress dose steroids just before the high-risk surgery, and then you can continue their steroids after the surgery, of course. If they have a mechanical prosthetic valve, you want to give antibiotic prophylaxis for any dental procedures. If they are transplant patients on certain immunosuppressants, especially like the sirolimus, which is an mTOR inhibitor, just to help enhance wound healing. So you want to back off on those or find an alternative during your surgery preparations, so that it doesn't delay wound healing in those cases. And of course, there are other considerations that I can't really exhaust. So you review the peri-op risk with the patient or the healthcare decision maker, and it's a major process before you do any, and you want to have all this information, before you present it to them, so that again they can make informed consent prior to the procedure. And the providers, especially the surgeons, the anesthesiologists, must be prepared to explain the procedure to the patient, review the risks involved, and be ready to answer questions and address concerns raised by the patient or family members involved in decision making. Okay, I hope this was very helpful. And again, this is not exhaustive, but I hope this will give you a guide in your pre-op evaluations for patients. Thank you.